This session to Seoul National University. Are you ready, Professor Kim?
Yes, we are ready.
Would you explain your
Welcome,
team and your patient profile?
Welcome again to second live case in SNU Hospital. I'm H.S. Kim from SNU Hospital. We invited a global star in the field of CTO, Dr. Yasumi Igarashi, who has been a course director of Sapporo Life for many, many years, and he became another director for the next CCT.
Yeah.
Thank you very much for
Thank you for invitation. Today I will support you to lead successful result.
And Dr. J.Q. Han, Jung-Kyu Han, and Dr. Hak-Seung Lee, my fellow, and my staff. There's very few staff. Okay. Let me introduce slides. Slide, please. Okay, second case, CTO. 56-year-old male, is very young man, experienced chest pain. Angiography performed and showed mid-LAD CTO at LAD diagonal septal trifurcation site. Antegrade approach to mid-LAD CTO was performed and failed. Next. Age 56 years without any significant comorbidity, but symptomatic. Plus, there are several medications, and target is LAD CTO. Plan is retrograde first because of two reasons. The first one is retrograde septal collaterals are really wonderful, and antegrade failure. I usually use retrograde guiding catheter 8 French, but in this case, septal collaterals are visible and big. The 7 French would be fine to support the passage of microcatheter through septal collaterals. Wire, my favorite is XDR or SO3 with core cell support. Antegrade guiding catheter, ordinary 7 French. If it's necessary, I start Gaia first. Next. ECG is very important to determine the viability of CTO segment, Q waves in anterior wall. So it may not be necessary to do a CTO, but plus symptomatic and echo shows contractility of anterior wall, no thin skull. Thus, there must be a viable hibernating myocardium at anterior aortic infarction territory. Plus, furthermore, systematic SPECT showed perfusion defect. That is partly reversible. That's the rationale to do a CTO intervention for this young patient. Plus, CT shows a little bit difficult situation. At proximal stump, there is numerous fine side branches that may mislead the soft antegrade wire into wrong directions. But good sign is on the right side, no calcification, and CTO segment X is not so long, actually very short. Thus, when we repeat the antegrade approach, it may easily pass to the distal to the lumen. Plus, here is the angiography that was performed in first trial. Anterior stump looks bad with various misleading side branches. Plus, retrograde injection shows good sign. There is several good septal collaterals from PDA to mid-LAD. Plus, first attempt was done by a young doctor. He used Sion plus. Then just the side branch is damaged, is stopped, plus. The issue for this case, is there rational PCI for LAD CTO? Yes, symptomatic, young age with long life expectancy, and viral myocardium exist. What's the technical strategy? I tried retrograde first because there is definite septal collaterals from PDA to mid-LAD. From now on, I'd like to show the angiography that taken several minutes ago. Angio, please. Here is left angiogram. We can see LV contractility is observable in apex, a viable myocardium. Plus, cranial view, see mid-LAD, CTO, plus epicranial view, we can see sluggish visualization of distal through LAD. Plus, here we can see several fine antegrade channels, but still there is some misleading side branches. Plus, spider view, plus caudal view, plus retroid injection, we can see a definite collateral, plus from PDA to mid-LAD or distal LAD, plus arteriocranial view, plus arterial view, plus arteriocaudal view. For your convenience, we took many angiograms for you to plan your own strategy for this case. Plus, then we took a bilateral injection. We can see it's a fine connection, but I'm not sure that is true connection. Plus, arteriocranial view, plus a little bit RAO.
It's the first time I tried to integrate it.
So did you remember all the pictures? Here, there is some connections, but it's very tricky at the proximal part. For the time limitation, I'd like to do retrograde approach. That would be faster than antegrade. Plus, here is an injection. Plus, then this is a selective injection to PDA.
Professor Kim, before you explain
Yes.
your progress to procedure, I'd like to
Yes.
ask to panelists, it's the first time, which approach is better, prefer antegrade or retrograde? Actually, these patients already failed antegrade approach, but this time your angiogram is a fine tapered antegrade flow. We'd like to discuss about that. Another attempt or retrograde firstly. How about
Is there anybody in the panel that would go to a retrograde approach as the first choice? Yes?
Yes. Yeah, I would go with the retrograde because it is already somebody has attempted antegrade, and the retrograde channel is much better than antegrade, where probably there's already a dissection and false, maybe couple of lumens over there, and we might end up with still spending a lot more time.
XTR.
I don't agree with you, Ramesh, because we see that the retrograde here is either going to the LED but very close to the occlusion. The distal connection, which is probably more adequate, is coming from right ventricular branch, and this is epicardic, and is going to more distal LED.
I truly agree.
Personally, I don't think the retrograde is easy in this case, so I will try. I'm not sure I will be successful, but I will try with a soft wire like XT to do an antegrade approach.
Sion.
I completely agree to what you just said. You see, the retrograde approach, I mean, I wish them luck, but the retrograde approach here is not easy at all, just because of the reason he just mentioned. And regarding the antegrade, that was done by, as he said, by a young guy with no dual injection, and it looks smart now, the antegrade, much more promising than it looked in the first attempt. But I trust Dr. Kim. If he chosen the retrograde, we trust him, right? He's the organizer of this meeting, right?
Yes.
Test.
So I think that it depends on the operator's experience.
Dr. Kim, when was the last time you failed the antegrade approach? I mean, the young doctor.
What time? When?
Yeah, how long did it pass?
2 weeks ago.
2 weeks ago. Okay, so it's too early maybe for retrying the antegrade approach at this point then.
I agree. That is another factor that I do retrograde first.
Yes, we already discussed retrograde is okay.
It is overlapped. That's view is overlapped.
Would you explain your procedure?
So I'd like to select the proximal receptor on the RAO caudal view.
What kind of wire do you use?
First, Sion plus injection. A little bit different size range. No.
Which wire you use?
Sure.
Sion. Test it. And okay, a little bit cranial.
Yeah, yes, I agree.
No.
What
Understand?
wire is that, Dr. Kim? Sion. Yeah. Yeah, Sion. Yeah.
Powder. Yes. Test it. Sure.
Among panelists, which other guide wire would you recommend in this case?
No, I think that for this stage it is the right, for this,
Sion.
stage it's the right wire. It's a beautiful wire. Later on it'll change it probably, but right now it's... Would you think of another one? We all agree.
It must be a wrong channel. Okay, I changed to XDR.
You see he's out of this... It just started.
Test it. Equals side branches. That is good. Test it. Another septal. That is different one.
If you doubt that cause, tip injection is better.
How about this? It's totally different channel than we intended.
I recommend to advance. And
Tip injection might be here. But there may be some overlapping of the side branches.
yes,
Okay. So we can show you the tip injection profile of this case at this location.
okay, all right.
Just see. So we need a big band of the wire tip.
And I strongly recommend to check from another view.
Another view?
Another view is
Okay.
very sometimes useful to identify vessel code.
LAO view? Epicranial? Just areocranial view? Areo?
No, LAO, sorry.
LAO?
LAO is better.
LAO?
LAO.
Okay. A little bit more.
No cranial.
카테터가 가리잖아.
No cranial. No,
Okay.
simple LAO is better. Okay, strong angle.
Big band of the tip.
Professor Kim, I have one question to you.
아래요.
Okay.
Dr. Finkelstein, Ariel, when would you switch? I mean, we recommend in the US hybrid method. You try retrograde. I probably would have shifted to antegrade at this point. In your experience, when would you switch from retrograde to antegrade? How long?
Well, you know, it's very difficult to stop a procedure at that stage because right now it looks like he's doing a very good job. The only point is that I think that either he's going to another septal or he needs to make a strong band in the septal that you've chosen.
소재로.
But I think, you know, it's more a matter of your personality than your knowledge.
It looks
And
good.
I think that for me personally, it would be very, very difficult to stop the procedure now
No.
I'd rather go as much as I can with contrast media, with time, with irradiation, and with this way. And if it doesn't work, then I'll schedule him for another time to integrate. But
Different.
I won't quit right now because I think that he has a good chance.
Because there is a acute band at
Yes.
the lower part.
That's what we're talking about the acute band over there.
Okay, I tried SO3.
We've talked about this band in the beginning when we saw it.
Yes.
And but I truly didn't realize that it would be that difficult.
Pre-shape.
Pre-shaped?
Yeah.
Already pre-shaped. That's I like it.
I would pull back the corsair. Yeah, I would pull it back and because there's another, as Eve was saying, there was another
I know.
epicardial. I would pull it back.
That's why
I
truly thought integrate is much easier.
It was full. Yeah.
Like, look,
Yeah, I guess.
No?
the point is that
Yeah, okay.
that's good. That's
Oh.
Test it.
retrograde. He brought a special guest for retrograde.
Not good?
Still, yeah. Very tough case.
Why not pull, Dr. Kim, why not pull back the corsair a little bit? But I think there's a distal channel, another septal.
Okay.
But we don't have the...
Okay, 쓰네.
Yeah, I guess.
Septal channel disappeared. So I have to do septal surfing?
No. That is a very not promising method.
How about that inferior branch?
Another.
Dr.
inferior
Kim,
branch.
can you show us for a
There is
minute the
a-
previous injection so we see the septal
Yeah.
that was before?
In areocranial,
So
we
I
saw
just
a
change,
Very important.
A little bit distal.
That's root is better. Yeah. So how about that? Just.
There is tricky side branches.
Yeah. Very often this type of collateral channel is very tricky. And so many bifurcation and acute angle. So sometimes very difficult to select target one.
It's wrong direction. Test it.
Yeah, that's the one.
Here, there is a resistance. It looks fine, but not good. Test it. Another branch.
At the beginning, we saw another channel when you were in areocranial. If you can go back to it, maybe we'll see it.
How about other selection? Minus. How about distal?
Yeah, the
More distal?
Select and chip injection. Yeah.
Okay.
You see here, you are in the superior branch. If you look at the inferior branch,
Pull back.
go down there, you will go
right
this
there.
one. Try this one.
I recommend
TIV injection.
yeah. To visualize site.
Okay.
삼성 준비됐나요?
Yeah.
알겠어요. 프로페서
Here I
김.
can show you TIV injection.
야,
Yeah.
프로페서 김.
Hello.
야,
Okay.
your
Angel,
procedure,
please.
procedure. Yeah.
Andrew, please. Here is the minus. TIV injection of the septal channel, but there is a steep angle. That is a problem. Thus, we take this view minus. This is RAO. It's good collateral. So I expect it is very easy, but turning point is very difficult. Plus, like such a deep band, so always wire just straight away. Plus, then in this angle, I try to negotiate in the left acute angled through pathway like this, but it is very difficult because there are two deep band plus. That's good sign, plus. But it is not advanced because of two big band, plus. Then I try to surfing. Like this, plus. It goes another invisible septal channel. Then its problem is we expect wire into the expected big channel, but this channel is very narrow. Then it is very difficult to advance microcatheter. I took 7 French retroguiding catheter. So backup is very insufficient to advance the microcatheter through such an unexpected, narrow, invisible septal channel. So I should do my routine, 8 French guiding backup catheter. Okay, plus. Then I use side anchoring balloon technique to increase the backup of retroguiding catheter. And 2.5 millimeter balloon is not sufficient. Thus, I'd like to change 3.0 balloon.
But okay, my idea is okay, change to the Carabel, one option. Because,
Carabel, okay.
Because this channel is a
RAO.
very tiny, so
So there are several options to make sure more strong backup with bigger balloon, anchor balloon, or change the microcatheter.
this anchor balloon position is not changed. So anchor force is I think maybe enough.
So if you'd like to change the microcatheter, another one,
To Caravel.
Yes, Carabel is one option.
deflation,
You have Caravel.
Then
LAO. Okay, stop. Anchor.
yeah,
Carabel, please.
12. Okay, all right, enough. Long Carabel 150.
So I strongly recommend you to use routine 8 French backup guiding catheter. Because sometimes like this, it's visible big septal channels actually difficult to navigate. Then septal surfing, then enter through the smaller septal channel. In that case, backup support is necessary. So I changed to another new caravel to wait for fortune.
And please stand by another new Corsair.
Balloon has, okay.
Corsair is sometimes surface coating is not so, durability is not so good. So sometimes change to new Corsair. Very successful.
Deflation. So Corsair is introduced, and then I advance anchor balloon to RV branchy. Okay, inflation. Then do my best, RAO. If I convey the microcatheter to LAD, then Dr. Igarashi will take over me. Make sure the guiding
Because
catheter
it's
still resistance.
maybe this channel is very tiny.
Tiny.
Yeah.
So why don't we ballooning?
Ballooning is one option by 1.0 because 0 is
1.5, 1.0?
1.0.
Okay, 1.0 balloon.
But you try again. It looks better compared with previous Corsair.
Still,
more
guiding catheter
yeah.
is prolapsed. Yes, still balloon is smaller. Zero balloon, anchor. Okay. I changed to 3-0 anchor balloon to make the back support stronger. I use Abbott vascular balloon track because I think it is a best balloon in terms of trackability. Nominal. 따위가 안 들었어? 오케이. It's impossible.
If it doesn't go, would you try another septal, the proximal one, Dr. Kim?
Before that, I would like to do septal inflation, septal vessel inflation by 1-0. Okay.
Yeah.
Deflation. AP. So I retrieve the caravel.
Please stand by 1.0 because 0 is available. Yeah. Okay.
You probably have one more balloon.
balloon.
Dr. Kim,
Yeah.
Hi, it's Eric.
Yes?
Do you think that trying gently to cross with a tonus would be too aggressive here?
Yeah.
Yeah.
I don't believe tonus. I have numerous bad memory with tonus. So I strongly discourage the usage of tonus.
I'm talking about the good old tonus, not the newer ones.
Yeah, tonus is a definitely larger profile than the caravel.
So let us see the deflation.
Because,
See the effect of septal channel dilatation.
yeah. With the 1/0 balloon, right, Dr. Kim?
Yes, 1-0. And then I inflate the anchor balloon to RV branch. Okay. Good, okay. Inflation, nominal. Then I advance the balloon. Yeah, balloon is also difficult to advance.
Yeah, but you can go up there and then advance it further.
Okay.
Okay, go. Go
Okay.
advance. Yeah, okay. Congratulations.
Oh, so,
오케이, 저장하고. 자, inflate. 오케이. Inflate. 12. 14. Okay, deflation.
Okay.
yeah, small
14.
balloon.
1-0, deflation. Septal channel dilatation.
This is Japanese
Inflation.
Kaneka balloon.
This is an RX balloon.
Kaneka balloon.
Yes, because it's zero.
Japan.
Probably this is one
Deflation.
of the best balloon to overcome this kind of situation.
Inflation. 14. What's the yellow blood pressure line? Deflation. Okay, open. Inflation.
Yeah, but
Deflation.
we just don't want to
And I reintroduce
Smooth?
smooth,
Yeah, okay.
smoother than
do
before.
smoother than before. Right?
Inflation. Deflation. This is the second time that I perform septal channel balloon dilatation. Inflation.
Cut
Deflation.
technique error about over 10
Always,
years,
always.
10 years ago. This kind of technique is very
A little bit better, but
yeah,
still there
common.
is a resistance. But
But
it
it's
looks okay.
Yeah, I think so.
Then kettlebell once again.
Yeah.
I have to save my energy for the next TAVI case.
Professor Kim,
Okay.
we have
Deflation. Yes.
5 minutes left. Would
Okay.
you,
What I'd like to show you is just pass the microcatheter.
thank you. Yeah.
Okay,
After then,
microcatheter,
you explain your
Inflation,
further plan
anchor.
to our
inflation
class.
anchor. For the plan, just deliver the whole process to Dr. Igarashi.
Probably this case, antegrade preparation is difficult because CTO entry point is not clear, and microchannel is detected. So a direct crossing is, I think, best method to, in this case.
Okay, deflation, anchor balloon. Okay, just anchor balloon introduced to RV branch. Inflate,
All right.
anchor, then RAO. So this is really moment
Of truth.
Catabolic pass through the channel.
Okay,
Beautiful.
Yes. See. Then reposition the little wire,
Okay, chip injection.
advance a little bit further, and Dr. Igarashi recommend the chip injection. Why?
Dissection.
Too deep, too deep. Okay, before.
Epicrania.
Yes. Wire shape is knuckle shaped. That is the reason why dissection.
It's dissected,
Yes, yes, dissection. Dissection.
so I don't like a tip injection.
But
Okay, just what kind of wire do you recommend?
you should put back more a little bit.
Okay,
Do you think that was from the tip injection or from the wire?
No. This case is wire-induced dissection.
Wire-induced
think.
dissection.
Yeah. Wire shape is
CLCO wire.
But
just
earlier,
before
you-
this delivery, knuckle shape. So.
No. Original CO.
because earlier the wire was in a good position in the other septal.
One more,
So I was
yeah.
wondering.
So integrate.
How about
Okay,
antegrade
maybe
injection?
from this position. No, yeah.
Yeah. Okay. I will introduce the wire until the distal stump, then advance microcatheter, then I change the wire, more appropriate one, such as Gaia first.
Professor Kim,
Yes?
we have to close this session. We are thanks
Okay.
for your
We
challenging
would
case.
like to show you the
Yeah.
final results just before the next or after next slide.
Yeah,
Thank you very much for your support.
Thank you.
Thank
Dr.
you very much, Dr. Kim. Beautiful case.